So is it visible now?
Yes, it's visible, Dr. Ketki, but I think when your OSCE is on full screen, you'll not be able to see the chat. So I'll just tell you what the answers are being told by the students. Okay.
Okay, fine. Okay, we'll start then. So this is a term neonate with respiratory distress on day 2 of life. Can someone tell the diagnosis from this is a spot diagnosis on X-ray. If I
So
don't play the
pneumothorax.
okay,
Many of them have answered as pneumothorax. Left-sided pneumothorax. Yes.
but okay, fine. Should I proceed?
Yes.
What the sorry if I don't play this screen, no, then the answers will be visible on the side. If it is a pneumothorax, no, what will happen here? You will get a pocket of air, but a normal lung which is compressed, that thing also you will get. So, and here you can see in between this also, in between the this is the black shadow where you can see those markings. Can you see this lung markings? So it is a congenital lobar emphysema. Though it is rare,
Some.
but any one of them have answered this as a CLE?
Yes, some of them have answered as CL.
Okay. Yeah. So if you get pneumothorax, no, it will be a classic lung border will be seen here. Since it is overinflation of whole lobe and the parenchyma will be normal. It is a developmental uh, s- uh, deformity during the lung development. So there will be the respiratory distress soon after the birth or within 6 months also over a period of time we can get the symptoms. And this is due to a lung, most common it is the left upper zone, I think, upper lobe. It gets over expansion, it compresses the another lobe, and you can see there is the mediastinal shift and the another lung, it will be collapse consolidation, you can see. Okay. So this is what the sir was trying to ask in the last one, this thing. No, what is it called as? It is a scalar, not a graph. This is a scalar. So how to increase mean airway pressure in this given unit? And what is the formula for mean airway pressure?
So some of them have written to increase PIP and increase TI.
Okay, what else? And what is the formula? How do we calculate MAP? So if the lung is not recruited, if there are still chest retractions are there, then we are supposed to increase the MAP. So how will you increase? So should I go to the answers?
Yeah, some of them have given the formula also, but it's written.
Okay,
So
fine. So nowadays, actually, most of like few of the ventilators they might give you map directly, but for us to know how does a map how is this map affected by it is affected by PIP, inspiratory time plus PWP also and expiratory time. So this is the formula and how to increase the flow. Sorry, how to increase the map is one thing is you can increase the flow, but this is not the first thing. The first thing is to increase the PIP. We can increase the PWP also. PI we can increase, and obviously the rates we can increase. One more question in this scalar is there is something grossly wrong in this scalar. What is wrong? Ideally, you don't want your baby to show this graph, right? Anyone
no
could write.
answers
That's
yet.
it.
Not yet.
Okay, fine.
I time
So
is more than the expect, and the TE is what they
okay,
have written.
accepted that this looks little longer than this. That is okay. Is my cursor visible?
Yes, it's visible.
Yeah. So what you can see here is it is
Sudden
acute
rise in
angle.
PIP is also one of the answers. Yeah.
Okay, great. So that is what I was expecting is you don't expect this 90-degree angle. There is a steep there should be either a curve or this angle should be obtuse. So here it sounds like somebody had accidentally set a flow of like some more than 6. So here we have to reduce the flow. This is too much. And obviously the expiratory time, it is looking smaller as compared to the inspiratory time. Okay. So this recently last week we had a baby with the positive family history. So what other system abnormalities will you expect in this baby when you see this case? And what is this condition
Waterworks
called?
syndrome, one of them has answered.
These maybe the syndromes associated system will you see? Okay, fine. Waardenburg syndrome, you can tell.
White forelock piebaldism.
Oh, what other organ system involvement can be there?
Hirschsprung's developing.
Hirschsprung. Okay, great. Actually, this baby had Hirschsprungs.
Nervous system involvement is also what some of them have written.
Since this is a neurocrystopathy, CNS, not all the cases. Okay, CNS system we can think of. So this is called as poliosis. And most important, most common, it is sensory neural hearing loss bilateral, which is the worst. After that, Hirschsprung disease, it may be with that Waardenburg short type 4. Iris hypopigmentation, skin hypopigmentation lesion also you can get. Okay, though this is a rare scenario, but whenever you get such babies, uh, please try to go to the diagnosis to prevent the recurrence in next pregnancy. The best part about these IEMs or such disorder is they are autosomal recessive. So next pregnancy can be prevented, which if this disease inherits. Okay, again, this was the case we saw on the last week is this neonate, we have given CPR. After that, he was stabilized, but his heart rate went to 280 and the ECG was this. So what does this ECG tell you and how will you manage it?
SVT, some have written ventricular tachycardia as well. And management with adenosine.
Adenosine is for SVT. See, there are narrow complex arrhythmias and wide complex arrhythmias. So what is it? Is it wide or narrow?
So they've answered as wide complex, wide QRS arrhythmia.
So this was the, now can you frame your answers?
So all of them have written wide QRS with VT and amiodarone.
Okay, fine. So this we can go. Baby had ventricular tachycardia. Uh, since it is a very terminal event, um, not with much good prognosis, if the baby is hemodynamically unstable, here I have misprinted. So if the baby is pulseless VT, then what do we do is the synchronized cardio version. We start with 0.5 to 1 joules per kg if the baby is not responding. You go up to 2 joules per kg. If the baby is hemodynamically stable, then only go to amiodarone or lignocaine can also be given. So it is a wide complex arrhythmias. Okay, and post CPR again, these are more common. So this is what is the diagnosis in this neurosonogram? Arrow is also pointed.
So they've written periventricular leukomalacia, cystic PVL,
Okay.
not much on the grading though.
Yeah, okay, fine. So this is the Debris classification what we follow for periventricular leukomalicias. Grade 1 is generally we repeat. Grade 2, these are small localized cysts in the frontoparietal region. And this baby, it looks like uh, grade 3 where there are extensive periventricular cystic lesion involving frontoparietal and occipital areas. And subcortical lesion we might not see here. So these are the things which you are supposed to see when a baby is getting discharged. The preterm baby before discharge or at 36 weeks when you do NSG, it is not for IVF, it is mainly for the periventricular leukomalacias. Do we do routine MRI for those discharged babies? So we don't do routine MRIs for preterm babies, but we do um, NSGs at 36 weeks to look for periventricular leukemalacia. Okay, this is amplitude integrated EEG of a term baby showing this rhythm. So can you tell me what is this? Is it continuous, discontinuous, or like that?
Discontinuous, some have written burst suppression as well. Some have written status.
One clue is what is the normal voltage do you expect in a normal baby if you put simply AEG? What is the normal thing and what is abnormal? So first thing is it a normal or abnormal?
So 5 to 25 volts is what they have given as the range. More than 5 and upper limit more than 10 to 25 variables.
Okay,
And they've written normal as continuous with sleep wake cycling.
okay, yeah, fine. Okay, then we'll go to see, even if you don't remember anything, if we just remember this chart, this is fair enough. So more than 5, more than 10, it is normal. And as you can see here, this is the sleep wake cycle. Here it is the sleep wake cycle, what we can see. And obviously, it should be more than 5, lower limit, and the upper limit should be more than 10. But what happens here into the discontinuous normal voltage is, what can you see here? It is the lower limit, it is less than 5, and upper limit, it is more than 10. Um, what do you see in the burst suppression is again a very wide zone of bursts also you can see here, and the electrical currents what the brain is throwing, it is over a huge range of time. And the most characteristic is here what you can see, the lower margin variability, lower limit variability, it is gone into the burst suppression. So as you can see, all these are the serrated margins, serrated things here, the lower limit, it is flat. So this is what the burst separation looks like. So this is just the photo I have taken from here. It the lower margin, here you can see the machine itself, it will give you it is less than 5 lower limit, and the upper limit it is less than 10. So it is somewhere low voltage. The prognosis of low voltage or the flat trace, it is not as good as other things. So this is one of the prognosticating markers. So here what we have seen in this photo is low. Okay. Can you tell me the name of this graph and what this diamond shape down blue color indicates?
So forest plot is the answer for the name of the graph as per the students. And
This diamond, what does it tell you? Uh, See, okay, why should we know all about the statistics and all this? Uh, Sometimes one MR person will come to you and he will try to sell some medicine showing this graph that see, this is very effective. I mean, this medicine is very, it has shown statistically significant and all. But we, being educated people, should be able to finally dissect that what does it actually tell you, because those person who are selling you, they won't tell you the side effects or this smaller things. So what does this black box tell you, or why is this small? Is this diamond will tell you the pooled estimate. So what was the final result of all the studies? Okay, this is the one study, this is another study. So these are all the studies, and what was the final effect, especially in the cases of meta-analysis? They will do analysis of all the studies and they will pool the results, and this diamond it will tell you. So this diamond, this one vertical line, it is called as line of no difference. So since your diamond is not touching this means your results are statistically significant. So whatever you have done, it works. And the corner of this line will tell you the confidence interval also. Okay, so whenever you get a diamond here down, it will tell you the final results. This black box, um, why is this small and why is it large? Anybody has idea? Black box.
They said sample size determines the size of the box.
Okay, this is one of the things. So it will tell you that what was the weight of the study. One thing is the sample size, and another thing is the precision of the study. If though your sample size was moderate, but your the precision in the study it is very high, then that also can be acceptable. So your study was either the sample size was high or the methodology or the outcomes were better. So this represents a better study as compared to this. So though these are the three studies, uh, they are touching the line of no difference, but only this two study have pulled this diamond towards the statistically significant side. So this we should be able to delineate. Okay, this is the forest plot. It will tell you multiple studies and the final outcome, especially in the meta-analysis. Okay, so what are the calorie and protein content in the colostrum and preterm milk?
So some of them have answered for colostrum, I think, 74 calories per 100 ml and 1.1 gram protein. Only person who has answered.
Uh, okay. So preterm milk, generally it will be little higher in the calories and much better into the proteins. So we must always procure preterm milk. See, donor human milk, if we don't have at all, then we should give. But the protein content, calorie content will be much lesser. So preterm milk is the best you can give to a preterm baby, especially in cases of this EUGR and growth restriction you will see, which again will lead to sepsis and the whole circle will be trapped in. So please stress on the preterm milk whenever you can, especially in the preterm babies. About colostrum, obviously the protein content is much higher as compared to the term babies, but the calories are around 58 to 60. Okay, so just one point I wanted to stress upon is the protein content. So protein, including the IGAs and other things, are much higher into the colostrum and preterm milk. So that should never get wasted. Okay, so what is this procedure? And okay, I'll tell you, this is the peritoneal dialysis, as you can see. What are the indications of PD?
Hyperkalemia, refractory hyperkalemia,
Okay,
persistent metabolic acidosis, AKI, and anuria, hyperammonemia.
okay. Any rare condition can you think of? Okay, these are accepted. So we'll go is in cases of AKI where there is oliguria and urea or unresponsive fluid overload, that conditions also we can do. The most important risk factor it is the indication is refractory hyperkalemia, which is not responding to the treatment. Severe metabolic acidosis also we can go, and inborn error of metabolism where you quickly want the abnormal neurotoxic metabolite to drain away from the body, like in cases of MSUD or urea cycle defect, we must initiate PD. And once the baby is stable, then you can shift to the other special diet. Okay, the last question. Mm, can you see? I hope it is clear. So, what is
Yes,
the
it's clear, it's clear.
what can you just tell me the diagnosis from this chart? Just looking at this chart, can you tell me the diagnosis? One of the diagnoses you will write on the discharge card. So this baby was born at around, girl baby was born at around 30 weeks, and today the baby is 39 weeks and she is getting discharged.
So extrauterine growth restriction is what they have all answered.
Okay, fine. What else can you see in this chart? Okay, so we can see the EUGR is there for weight, for head circumference, and for length also. So EUGR can be defined in all three zones because this baby, to label it as microcephaly, this baby was born at 50th centile for this head circumference. So maybe over a period of time, either some brain damage like PVL, either it has happened or it can be a simple EUGR for head circumference. Are you aware of any recent advances in the Fenton growth chart? So I think this is the
They
older
have
version.
said 2025 Fenton's growth chart, but and is now the new standard growth chart is what they've written.
This is not the standard growth chart. It is a reference growth chart again. Was India a part of this new or old growth charts? Simple yes or no we can use. Was it a
Mm,
standard?
they have not answered. Yeah,
Okay,
some of
okay.
them have answered as yes, as being a part of.
Actually, the answer is no. India, this what we can see here, it is the Fenton 2013. It was the second generation growth chart, and now, as you have said correctly, 2025 third generation growth chart of from Fenton has come. But again, India was not a part of this whole scenario. Again, it was a reference growth chart. It was just a meta-analysis, and they have retrospectively looked upon whatever the data people have published till now. So India was not the part of this. Okay, but these are told to be little better. Mm, then again, someone can ask you that what is the difference between the first one, like second one and third one? Why is it better? What are the changes? Okay, then can you quickly tell me what is this EUGR prevention care bundle? As the sir was asking, no, what bundle care will you give? So one is the how will you prevent EUGR?
So early enteral nutrition, adequate calories, fortification.
Okay, fine. So this is EUGR third generation. Main is the mother's milk, colostrum you don't miss upon, preterm milk you don't miss. Parenteral nutrition, if the baby is NPO, we have to start it from day one along with lipids and amino acids. Protein energy it should be adequate. And minimal enteral nutrition, if the baby is less than 1 kg, we can start. For more than 1 kg baby, directly we can start if the baby is hemodynamically stable on total or enteral feeding. Then there should be rapid escalation of feed, human milk fortification. It is shown to have much better outcomes on EUGR and early transition. Yeah, I think that's all. Any doubts or any clarifications?
No, no questions from the student side. I think it's great asking. Okay, I think we finished. Thank you so much, Dr. Ketki. It
Yeah,
was
okay. Thank you. All
very
the best.
interesting. Thank you. Good night.
Good night.
Merry Christmas to all.